Good morning, everybody, and my talk will be about the personal respiratory protection program. I'm a Russian physician, head of the TB hospital in Vladimir, Russia. And I will start from the simple example, my personal story. Just August 31, my wife, her name is Natasha, got sick, high fever, severe weakness. I'm a physician, I'm a doctor. And I suspected it's COVID. It's on the rise in Russia these days. And I had a trip to South Africa, what your wonderful country had. So what I did, I implemented short program for myself. So what I did, I implemented administrative measures to do the rapid testing for her. And before I confirmed the infection, I put surgical mask on my Natasha and I put respirator on myself. In the apartment we live in. So next morning she got the positive PCR results for COVID-19. Antigen test was negative, but PCR was positive, rapid PCR. So she stayed at home, started medications, very high fever actually. Very severe manifestations. I started dexamethasone, continued working in my hospital. So this is just the apartment. So what we did, we opened all the windows in the apartment. We are cold country, cold climate country. And in the apartment I use N95, FFP2 respirator, we call in Europe. So she's now doing well, just some weakness and no fever. Recovering, talk to her by WhatsApp. I'm here, I'm not infected. So IPC works, airborne IPC, airborne infection prevention and control. Actually, it's the same measures we implement for TB. It's about the pandemic preparedness. And for sure, the humanity should learn this lesson of implementing feasible, simple, affordable, effective airborne interventions, airborne IPC intervention. And airborne IPC was assessed by a group of the experts by WHO in 2019. And this guideline published by WHO is about the effective measures to reduce airborne TB transmission. And we learned during these 2.5 years of the pandemic that most of the transmission of the COVID-19 occurs through the airborne route. So it's actually about, not only about TB, it's again about all airborne pathogens and future airborne pandemics, which probably will come sometime again. And one of the recommendations included into this guideline is about the implementation of the personal respiratory protection as part of the program. It's not just respirator. We have to organize the process to have it workable, it's effective. And PRP is on the peak of the pandemic, or the pyramid of the intervention. So based on administrative controls, described earlier, environmental controls. And we just learned with you that ventilation and UV are not perfect. They do not reduce instantly the risk or the concentration of the particles, pathogens in the air to zero. And some risk remains always. So even with the highest rates of the mechanical or natural ventilation, there is some remaining risk. And only in complex we can reduce risk to minimal levels. So my talk is about the sustainable program building of personal respiratory protection program. And there are several components, and on my personal example, we can actually see that it works. I'm here, I'm not infected, and that happened in June back in 2020. And I'm, as a medical doctor, I see lots of TB patients, lots of COVID patients, was not infected at all, and I believe all the complex of interventions works. When I came to the general hospital converted for COVID, Russian hospital converted for COVID without any ventilation, with poor administrative control, what can I rely on? Only on this. And also by minimizing my time spending taking samples and washing, we were actually validating rapid molecular test, GenExpert SARS-CoV-2 Express. So I took lots of samples. I've seen hundreds, maybe thousands of infectious COVID patients, TB patients, and managed to escape. So well, part of the sustainable program is education and training, so I know how to use it. I did my risk assessment. I assessed the risk on August 31 and decided in this high-risk environment I need to implement a respirator. So I did some kind of zoning in my apartment, one bedroom for high risk for Natasha. On the opposite side, I checked the wind direction, so I put my room in the upwind part. Natasha's room was just across. Natasha again used the mask. I used N95 or FFP2. So it was just zoning of my apartment. And we do exactly this in our hospitals. When we convert hospital for COVID, we have to think about it. And again, in high-risk areas, this is a must. It should be used always. Another component, we have to choose effective certified respirators compliant with the international and national standards. And this is one of the components also. Without fit testing, I would never know, does it work for me at all. It's not surgical mask, it's a good filter. Without good seal, it doesn't provide air filtration. It doesn't reduce concentration of aerosol. So it's for a simple procedure called respirator fit testing. We'll have practical exercise with you. And it's easy to do. I do it annually, and all staff of the healthcare facilities which have a high risk of infection of airborne pathogens should do it also. And I learned, I strictly follow instructions to use the respirator accordingly, to don, to doff, and so on. So, who are high-risk airborne transmitters? Actually, it's not patients with a known diagnosis, proven diagnosis. It's the first stage of the disease, the first days, maybe weeks for TB, days for COVID. Minimal symptoms, no diagnosis, no confirmed tests. So Natasha, first evening with fever and weakness before she was infected. She was highest risk transmitter. So this is time to implement when you suspect, and it's about risk assessment. It was told before. For TB, I would say MDR TB wards, both in Russia and South Africa, remain high risk. We implement all hierarchies of controls. We have natural or mechanical ventilation. We have upper room UVGI, separation and isolation. But in many cases, we do not have fluoroquinolone rapid testing, molecular testing. So we start drugs without knowing resistance to fluoroquinolone. So we stop transmission immediately for rifampicin resistant cases, but XDR, pre-XDR patients continue transmission. And this means without this, our staff is not safe. So we have to analyze complex of factors in healthcare facility, in your apartment, in your family, everywhere, and it should be part of the activities, everyday activities during these pandemic times. And signage, I didn't put signage in my apartment for sure, but in the hospitals, in hospitals, it's easy and it's really important and really effective measure. It's simple just to notify people, do not go or put on fit tested, certified respirator and go to see patients or to visit somebody and so on. We've been filming excellent district facility here in South Africa with implemented airborne measures, and I've seen lots of signage about masking, about respirators, and about other practices. So the healthcare facility should develop the policy on fit testing. Should be simple and inexpensive fit test kit available for testing staff. So everybody should understand what model, what size of respirator should be used on daily basis. And nurse or technician can be trained, easily trained, and takes just 7 minutes to do. So I'm sure it can be done in every healthcare facility, like we started to do long years ago, 20 years ago actually, and now we came prepared to airborne pandemic of COVID-19, and we did have TB patients and COVID patients. We didn't see any transmission between patients, cross transmission between patients of COVID, because all this complex of measures actually work effectively. So the qualitative fit test will be discussed in detail during the practical exercise. There is a simple and brief technical sheet published, and there are many copies here. You're welcome to take them. We will have respirators for fit testing to practice, and will be a little bit later will be discussed. These materials have been developed by ETTi, and they are available online and here on paper. You're very welcome to take them home. It's feasible also because it's easy to prepare both solutions. Every lab can prepare both sensitivity solution and challenge solution using this simple protocol described here. Bitrex or saccharin available in chemical shops. It's easy to do and refill yourself. Like when I was preparing to the trip, I took fit test kit. My lab prepared the solution for me to practice here in South Africa for demonstration. Staff education is important. If without understanding, knowing the simple principles, without understanding of the difference between surgical procedure mask and respirator, it's impossible actually to use effectively respirator. And we should provide on annual basis trainings and refresh knowledge and notify people that it's actually really important to follow these policies. Policies and signage should help. This is an example of Russian posters we use in my hospital. Like a very long time, years ago, we, for not compliant staff, asked to make a picture of the closed people or animals, and it's in Russian, but it's about my health is your health. I have to protect my health. I will not bring TB home, so on. It's about improving compliance of the patients. It's about education and training. So not only these disposable respirators actually good and effective and not quite expensive to use, but also elastomeric models are available. They in the long run then actually cheaper to use. They're not that comfortable, but some healthcare workers prefer, and I would say they last for years, and just filter replacement and cost it's not too high. In my hospital, it's for bronchology, for high-risk areas in the lab, and pathology, for autopsy. So, and other healthcare workers who prefer elastomeric to comparing to the disposable respirators, they should be offered these models. And again, it's actually cheap in the long run. So we did the assessment of the needs, how many respirators should we supply before pandemic era, And now with the COVID risk, actually the need for respirators is much higher than just for TB in TB facilities. But again, I learned that most of the transmission again occurs through airborne route, not from the contact route. So actually, in some cases, I unintentionally reused respirators after COVID, and again have not been infected. So safe practices are important. And procurement is really important also. So the people who are responsible for procurement should base the purchase decisions on fit testing. They should understand what kind of models, sizes they provide based on the protocols of the fit testing of the healthcare staff. And there are standards. There are US standards. I'm sure you have South African standards, European standards, Russian standards. They, in many cases, they are very similar to each one. So there are lots of fake respirators in the market, and we'll test with you today during fit testing. Different models, we'll see. You got respirator or mask KN95 in your backpacks. Here at the conference, let's check that do they look? Just check in your backpack, there is one. So is it really a respirator? Is it compliant? Does it protect us? Does it work at all? It's easy to check just by. There are models of respirators available in Russia and Belarus. So they marked accordingly, but if you do simple fit test, you'll find out they do not filter at all. Huge leakage, huge risk, loss of life, loss of health, again, and it's preventable. Nice resource on CDC, US CDC website listed models and manufacturers producing the respirators, and you can always check if it was proven by independent parties, responsible parties. What about reuse of disposable respirators? Some people believe that single-use respirator is just to use it once and put it into the trash after single use. In fact, for TB, it's not true. For COVID, it's questionable still. But for TB, for sure, it's not true. If there is no contamination, if the respirator provides good fit, if it's not broken, and you see that your fit check, not fit test, fit check, when you don it, shows there is a good fit, so it can be reused easily. And personally, as if I have no COVID patients during my shift, I reuse my respirators full 24 hours duty if I'm on duty on Sunday, for example, in my hospital. So donning is extremely important. Sometimes we can see that respirator is certified, it's good of quality, but it's not used properly. Some wear them on the neck, on the front, huge gaps, so not filtered fresh goes without any obstacles to the respiratory tract and can infect. So donning instructions are put on the respirator box package. Always it's part of the standard, so we have to just follow the instructions, simple instructions. There are compliance issues, it was discussed in the first presentations today, so we have to somehow deal with it. And I would say COVID had a very substantial positive role when everybody demanded good PPE, and it's now not a problem again, so we have just educate and work, and maybe for some healthcare workers or people choose different models. We procure usually at least two or three different models for everybody to be satisfied and to have a fit test passed. I already talked about difference between disposal and elastomeric respirators. and the care is different. Will not waste time for that. And disposal of respirators is important part. They can be contaminated, that can pose a transmission risk for contact infections, including COVID probably, but mostly for Hep C, HIV, if it's contaminated by body fluid. So according to national standards, we have to dispose them as contaminated materials. So again, we followed all these circles of several simple, very simple interventions. And our goal is to be prepared for TB, COVID, and next airborne pathogens. Last pandemic, the current pandemic, had a mortality rate 1-2% only, and it was a disaster. What happened in future, it will be 20-30%. So airborne IPC, TB IPC should be up in the agenda. It's not only goal of the healthcare workers, it's a global concern. I think we have to think about PRP for the whole population. So thank you very much. That was my talk. Thank you.
Grigory mentioned that we have several information sheets in the back. This one is on personal respiratory protection. We have one on fit testing and one on germicidal UV, including lifetime costs and how to budget and calculate what you would need for GUV.
The Anti-TB Transmission Initiative, or shortly ETTi, is a working group of the Stop TB Partnership that supports the global fight against tuberculosis by focusing its efforts on preventing and controlling TB transmission. To learn more about ETTi and to keep up to date on ETTi activities, please join us following the link to receive our newsletter and follow us on Twitter. At the 7th South African TB Conference in Durban, ETTi presented Airborne IPC workshop. All lectures and exercises can be found on the ETTi website.